let me know if you. Thank you. Let me know if you can't hear me, and because my mic is dying, and I am going to talk about kind of used to be called a complementary and alternative medicine, whatever treatments for psychiatric disorders, and I don't like the word complementary because it sounds like it's an add-on. As hopefully I will try to convince you, is that I think these are and should be part of our treatment profile. And I cannot talk about everything. This is what I call a primer. So I'm going to focus on mood disorders. And I'm also going to, I'm going to give you a lot of information, partly because this is the only lecture that you get about this, but any of these topics are kind of a lecture by themselves. There is actually a whole course on lifestyle and nutritional medicine and psychiatry in the if you ever become a member of the American Academy of Lifestyle Medicine, and we have a behavioral interest subgroup. So I'm going to give you a lot of information, partly because I also want this to be your kind of a reference. You can access this lecture later, or you can ask me for my slides. And this is going to be focused, as I said, mostly mood disorders. And because I'm a perinatal psychiatrist, I'm also going to talk a lot about some of these things in the perinatal period. And the other disclaimer is that this is not my area of research. My area of research is the neurobiology of stress. I came to this because I used to do, and I still do consultations for treatment refractory depression. And I found myself saying, well, what else can I do about this? So for those of you who don't know me, I'm Juan Francisco Lopez. My nickname is J-Lo. Not true, it's Paco. And I'm all these kind of things. So I always come with a parental advisory because I sometimes use explicit language, bad jokes, controversial topics, etc. I'll try not to cuss. I will really try not to cuss. I promised my wife I wouldn't. She's a pediatric endocrinologist, and when I'm giving talks and she's around, she usually kicks me. So I'll try not to. But if it happens, it happens. What the hell? What are you going to do? So, and I'm going to I'll go out on a limb, and I'm going to tell you that I hope that this lecture is going to improve your clinical management of mood disorders. I always say, whatever, Lopez, you're a little bit narcissistic. And again, as I was saying to Andrew earlier, this is a it's a vast topic. We can only scratch the surface. I'm going to give, we cannot go a lot into mechanisms of all these things. There is a wonderful neurobiology behind this. If the spirit moves me, we can do a whole several seminars about this. But I'm going to also tell you some of the things that I usually do, and they're easy to do. So it's going to be a very practical lecture on things that you can do, things you can implement, and at the end I'll try to leave enough time to see whether if you have any questions about specific mechanisms. Again, what to call this, I start calling integrative psychiatry. We usually think of mental illness in general, mood disorders in particular, as having a multifactorial etiology, right? We have our genes, stress, both early life stress and current stress, certain medical issues can affect your mood and can impact your brain, alcohol and other drugs. Those are kind of the bad guys. And in general, as psychiatrists, as clinicians, we usually use medication and psychotherapy. But there are other things that we know affect the brain, and such as light, exercise, nutrition, and the judicious use of supplement. And the key word here is judicious. And I'm not going to talk about light because you probably have another lecture on light. But these three things are an integral component of how I treat patients. And those of you who get supervised by me know that I pay a lot of attention to this. And at a very simple level, we know that these things affect the brain. We know that exercise affects the brain. We know that nutrition affects the brain. And we know that supplements affect the brain. And again, this is something that we all know, I think, that there is a bidirectional relationship between depression and chronic medical disorders. We know that if you have depression, it increases your risk for certain medical illnesses. It increases morbidity and mortality. And the other way around, certain medical illnesses increases the risk for mood disorders in general, but also for anxiety and depression. And there is a whole literature that inflammatory, vascular, and metabolic processes are involved in the risk of mood disorders, and vice versa. Again, it's a bidirectional thing. So I'm going to give you the punchline of my lecture. And the punchline is that these interventions, at the very best, will help mood, and at the very worst, will help decrease the impact that mood disorders and depression have in general health, both brain health, but the body health. So again, that's why I think this is extremely important for us, and not only psychiatrists and anybody who works in the mental field. And I think there are some people here who are not physicians. I'm going to try to avoid a lot of medical mumbo jumbo. I'm going to try to make it as simple as possible. I actually invited some of my patients. I don't know if they're seeing this or not. But again, this is something that can be, some of these approaches can be implemented by anybody, including non-physicians, although some of the things I think they're better implemented in consultation with physicians. So what am I covered today? As I said, it's a brief overview of a very complex topic. I'm going to talk a little bit about the relationship between mood and nutrition. I'll tell you my general rules on how to choose a supplement. You can take them or leave them. I think they're smart, but it's me. I'm gonna focus a little bit on omega-3 fatty acids because and mood, because I use it a lot, and most of my patients are taking this supplement. We're gonna talk about a few micronutrients and mood. Some of them, again, this is a whole different topic that we can have one or two lectures about. I'm gonna talk about a couple of adaptogens. What the hell are adaptogens? You'll see, and this is a specific kind of supplements. And then at the end, I will tell you about the wonder drug / complement treatment, and you'll see what it is, and I'm sure you can imagine what it is. So this is a big pet peeve of mine. I don't think we get enough instruction on this particular area. Certainly didn't have it. As I said, I came through this indirectly, through looking at how patients respond, the lack of response, and because of my interest in neuroscience, I begin to look into this and I implement it. But we don't. And again, this is the only lecture I think that you're going to have, and you can certainly use me later as a consultant or something. But we don't get enough information of this. And let me tell you, this is a beautiful example of how a nutritional intervention affects the way that people can respond to antidepressants, in this particular case, an SSRI. And this is a very old study done by some of my colleagues at Yale. And as you may have noticed, this is the metabolism of serotonin, how serotonin is made in the brain. Serotonin is 5-hydroxytryptamine. And the way the serotonin is made in the brain is that serotonin is made by the brain transporting to the brain of an amino acid called tryptophan. Now, tryptophan is an essential amino acid. What does that mean? Does anybody know what an essential? And I know, I apologize, it's kind of hard to interact in Zoom, but those of you who already took my serotonin lecture know about this. What kind of amino acid is tryptophan? What is it called? You guys know? It's an essential amino acid. Do you guys know why it's an essential amino acid? Can you tell them, Andrew, what's an essential amino acid? Why is it called essential?
We have to ingest it.
You have to ingest it, right? Your body doesn't make it. So tryptophan needs to be ingested to be converted into serotonin. And in fact, you can, and you know, tryptophan hydroxylase is the rate-limiting enzyme, and it is usually not saturated. And animal studies had shown that you can literally change the levels of serotonin in the brain by changing the amount of tryptophan that you give to the patients. So what this particular group did, this is a study where they looked at what used to be called a tryptophan depletion diet. They take patients that had responded to an SSRI, in this particular study is to Prozac. I'll show you in a second. And what happens is they put them in a psychiatric research unit, and for a few days, they give them a diet completely depleted of tryptophan. So in theory, I mean, it will decrease the levels of serotonin in the brain. Actually, the way they do it, they give them this concoction of amino acids that don't have tryptophan, but they also compete with tryptophan. So basically, your brain is not getting enough tryptophan. And this is what happens. And I just want to focus, again, this is the studies by Pedro Delgado from Yale. So you have people that had responded to SSRIs. And when you deplete them from tryptophan, their symptoms return. Now, there are ways of depleting norepinephrine so the symptoms do not return, and you can do the same thing with norepinephrine reuptake inhibitors, like tryptophan depletion doesn't do anything, but norepinephrine depletion symptoms return. But the point here is that for an SSRI to work, you need to have enough serotonin in the synapse, right? The way, as you know, antidepressants work is that they block the reuptake of serotonin, increase serotonin in the synapse, and then you have all these postsynaptic mechanisms. But if in the first place, I mean, you don't have enough serotonin, then the medication doesn't work. Again, this is a very dramatic intervention, but it shows the point that you need to have enough tryptophan in your diet to have an appropriate response. In general, most of us do, okay? And as I said, this is a very dramatic experimental intervention. But I worried, for example, some people that may genetically have a deficit in serotonin neurotransmission or whatever, a small or moderate depletion in tryptophan may actually impact the way that they respond to antidepressants. So one of the first things that I do if I have an SSRI non-responder is, can you tell me what you're eating? What's in your diet? I just want to make sure that at least from a dietary perspective, they're getting enough proteins or enough things that have tryptophan. Does that make sense? So again, an example of how a dietary intervention can alter the way that people respond to a specific medication. So in general, though, and again, I hope we all know this, good nutrition is very important. For example, clearly there is a protective role of the Mediterranean diet pattern in preventing depressive disorders. This particular study was actually done in Spain by the University of Navarre, I think, and they had been following young people for a while and seeing how they would stick to a Mediterranean diet. And what they saw is that subjects that stuck to a Mediterranean diet pattern, when you follow them up, have much lower rates of depression. So at least it is a protective effect. Now, it is a correlation. It could be that these people that were using the Mediterranean diet pattern had some other, lifestyle things that they were doing that were also protective, although they did try to control for that. The other thing is that, and so again, we know that at least has a protective effect. And that's not the only study, by the way. This is just an example, and I'm always putting all here the reference. You can go back and check the reference yourselves. The other thing is that we know that diets that are higher on the glycemic index are associated with greater odds of depression. This was a very classic study called the Women's Health Initiative observational study, where they have been following women over time, over several years, and they did a bunch of measures, health measures, diet, and they checked mood, etc. What they found is that women that at point A had diets that were higher on the glycemic index, because glycemic index, as you know, is diets that are rich in sugar and processed carbs, diets that make your glucose level go up and down a lot, and then they cause things like insulin resistance, etc. So not only does it have an effect in your body and in your risk for diabetes and in your heart, but it also has an effect in the brain. So these women had much greater odds of developing depression at point B. Again, point A had higher depressive rates, a higher glycemic index. At point B, greater odds of depression. Now, nutrition and mood is, of course, a two-way street. We know that nutrition affects mood, but we also know that mood affects what we eat. And I'll give you some examples. Particularly now, let's go to pregnancy, to the perinatal population. There is an interesting study where they show that women that had higher levels of stress had higher intakes of, the things that make us feel good temporarily, right? Fats, oil, sweets, snacks, breads, processed breads. And in fact, anxiety was linked or associated to higher intakes of fats, oil, sweets, etc. Interestingly, when they control for body mass index, for numbers of previous children, education, etc., it didn't change. So an effect here that, again, suggests that the way you feel, it changes the way that you eat. And of course, then it becomes a vicious cycle, because the things that you eat may affect the way that you feel on and on and on, like a negative vicious cycle. Now, why, at least certainly in not only outside pregnancy, but in the pregnancy period, we know, and there's some studies that that has found an association between unhealthy intakes of unhealthy foods during pregnancy and externalizing problems among children. And again, you have the reference there. And in fact, in general, there is also an association with maternal metabolic conditions like, insulin resistance, gestational diabetes, increased BMI, and is broadly associated with certain neurodevelopmental problems in children. And again, it makes sense, right? I mean, we're talking about an environmental insult, and I don't have, again, time to go deep into this, but we know that the intrauterine environment is an environment, and what the mom experiences can affect the development of the fetus. So now, interestingly, again, just to keep beating a dead horse, this is a famous study called the Avon longitudinal study of parents and children, and what they found is during gestation, higher depressive symptoms were related to lower levels of healthy nutrition and higher levels of unhealthy nutrition. And again, when you look at both depression and poor nutrition, both were prospectively associated with reduced cognitive function in children. Again, not, we're talking about statistical difference. We're not talking about significant, cognitive problems. Nevertheless, I mean, at least in a population sense, you have lower reduced cognitive function. Again, we don't know why, and there's some mechanisms that can possibly explain it. And they think that there is both that depression have a negative effect both directly and indirectly via nutritional environment. Again, this is just to point out the importance, if those of us who do perinatal work, and even outside the perinatal period, that we need to make sure that we assess our patients' nutrition, and we need to help them change. Yes, it is an association. However, having said that, associations, they don't necessarily imply causality, but they may. So again, the worst case scenario is you get someone eating better. The best case scenario is that you can decrease the risk of negative outcomes, both on the mom and for the baby. Now, again, those are correlation studies, and there are 2 interventional studies outside pregnancy, by the way. You can read it. I'm just going to put them in there. One of them is called the SMILES trial. The other is called the Health-I Med study. They're interventional studies where they actually used Mediterranean-like diet in people with depression, and they found that it works. So I'm just going to show you one slide. This is the Health-I Med study looking at the depression ratings. I think that they may have used something called the DSSS, but the interesting thing here, though, is that their control group was actually a social group with us. So they were getting, the way that they do this Mediterranean diet thing, they get together with the patients, they shouldn't have to cook and things like that. So there is a social component to it. So to control the social component, the control group is a kind of a social group that spend the same amount of time. So we know that social interactions and it's good for your mood. So you do see that people that undergo the social group, they have an improvement in mood of 3 months and 6 months. But the patients that follow the Mediterranean diet had a significantly better improvement in mood. So just to show you visually, and the same thing was found in the SMILE trial. So these diets, they work, and I'll show you a little bit later. I think some of the possible mechanisms, maybe not. Okay, actually, we're going to switch a little bit now. Let's talk a little bit about, okay, so diet, important, it's good. Diet is good for your brain, right? Good food, good mood, or good multiple things. So again, I don't like the word complementary and alternative, but this is to show you that a significant number of people, certainly at least 40% of the US use CAM treatment each year. Consumer Reports this survey and showed that 54% of Americans take a supplement, at least one supplement once a day. And in fact, in a UK study several years ago, they found that more than 1/4 of women reported using quote unquote, usually supplements, complementary alternative medicine during pregnancy. So it is widespread. Does it have an effect or not? So, but again, if you go to perinatal depression, we have to be a little bit careful because some of the things that we could do outside pregnancy, we are not sure whether they have an effect or not. So, but I'll show you the ones that we use, and certainly a number of these treatments may be reasonable to consider. for perinatal depression, but the safety and efficacy of many of these relative to standard treatments still must be systematically assessed and systematically determined. So, important thing, I apologize, and hopefully my dog will allow me to finish this thing because I'm doing this from home. One thing about supplements is that we know that supplements are not regulated by the FDA. So you have to be careful. In fact, I think they did a study many years ago when they took a bunch of supplements, I think from Walmart or something, and somebody checked whether they had what they say, and the content varied dramatically. So the way that I use supplements is I usually pick up supplements that of companies that send their products to a third party. There are three major watchdog groups that look into this. One is called the National Sanitary Foundation, really old. By the way, I think the National Sanitary Foundation has offices outside Ann Arbor. The most common one that people use is the United States Pharmacopoeia, USP, and then also Consumer Labs checks supplements. I usually use, the ones that I use when you look at USP means that, again, they have been checked by a third party. I am partial to Nature Made. I'll tell you why in a second, but just because I know when I looked into their chart and into their website, and I looked at what they do, and they send their products for confirmation to a third party. But you can choose your own supplement. It doesn't matter to me. This is just easier. Now, what are my broad rules for choosing a supplement? What you're going to find, obviously, is that you're not going to have because supplements are not patented or not, there's not a pharmaceutical company usually behind them. You're not going to have like large, massive numbers of studies like you see in antidepressants or psychotropics, etc. Right? So that's not going to happen. So I'll tell you my rules for choosing a supplement, because you have to use a little bit of judgment. And again, you can take them and leave it. One of the things that I use is the clinical evidence reasonably good? Now, what do I mean by reasonably good? Is there at least one double-blind randomized placebo study? If if is it a reasonable effect size on this thing? Again, you're not going to have thousands and thousands on some supplements you do, but in general, I just looked at that and says, well, listen, if it works for some people, it doesn't work for others, I still am going to try it, or I'll tell the patient about it, and I'll make the patient make a decision. So that's what I mean by reasonably good, at least one reasonable good trial. Now, the other thing that I looked at is, does it make sense physiologically? Does the way that this supplement works has to do with some of the things that we know about the pathophysiology of depression? Does it decreases the inflammation? Does it, decreases, improves the health of the neurons? So I'm a neuroscientist, and I looked at the basic studies, and I see, well, this may make sense to try it. Is it an anti-inflammatory? Does it increases dopamine in the brain, etc.? The third thing, and this is one of my biggest things, is there a good cost-benefit or risk-benefit ratio? If you have something that evidence is, it's okay, but frankly, there is very little risk to none of taking it, I said, listen, why not? The risk of doing this is very, very low. And for many of the supplements, actually, the risk of taking them is very, very low. And I can give you the rules that I usually use with them. I tell my patients, listen, this is what it is. There is a potential for this doing this, but in general, you have a very little risk, and also whether the cost is reasonable. And the fourth thing that I use is, does it help other conditions? If I use this supplement and it's helping something else that the patient has, why not? And I'll give you an example of this in a second. In fact, it is here. So let me give you this clinical case. This is a 25-year-old G1 P0 female. She's 24 weeks pregnant, and she has a history of bipolar 2 disorder and trichotillomania. And those of you who are probably in 30 years, you probably know where I'm going with this. She presents to our clinic with emerging symptoms of depression, 1 month duration. She has been stable on lamotrigine 200 milligrams, Seroquel 100 milligrams, no symptoms of depression, mania, or hypomania for the past 2 years. She elected to continue on the current combo of medications of Seroquel and lamotrigine when she became pregnant. She comes depressed with worsening depression. We try to increase Seroquel, resulting in significant sedation. She's kind of maxed up on lamotrigine, a little bit reluctant. Now, another thing about this patient is that she has a medical history that's positive for recent episodes of bronchitis and a possible diagnosis of alveolitis. So given this information, right, she has bipolar depression. We can maximize it. Let's say that she's doing therapy. You can always add therapy. But in terms of supplements or pharmacology, I mean, we can certainly add an antidepressant to do that. But again, what other things could you do? What could you do pharmacologically to treat her depressive symptoms? Does anybody wants to risk? What would you do? What could you add that is actually safe in pregnancy, by the way? Any of my colleagues know? I don't know if I'll tell you. You can give them N-acetylcysteine. NAC, N-acetylcysteine, in fact, is a mucolytic. It is used to treat alveolitis, bronchitis. It's actually used for also cystic fibrosis, by the way. And it turns out that there are several, both controlled and uncontrolled studies that have examined its use for symptom treatment and prevention, usually during bipolar disorders, maintenance phase, also in depression, in bipolar depression. Findings are mixed, but often positive, and seems to be mostly for depression. Frequency of many is unchanged. And it may offer a special advantage to bipolar patients with medical comorbidities, as I said. By the way, and another thing that NAC is used for is for Tylenol poisoning. It's actually quite potent and with acetaminophen poisoning. And as I'll show you later, there's a large study that showed robust improvement in depression, function, and quality of life when NAC was prescribed as an add-on to usual treatment. I'll show you in a second. It's a study that came out in biological psychiatry with patients with bipolar disorder that were still having depression, and they added NAC. And the other thing, and I think, in fact, I've seen some of the residents use this. It seems to be effective also in patients with trichotillomania, which this woman has as a comorbidity. So this is the study, and this is our depressing ratings. And this is just the effect size, which is a very good effect size. I don't know if you guys know what effect size is. Effect size is a measure of the magnitude of a change, right? You can have statistical significance, but the effect size is small. Effect size is how large is the difference between two groups. I mean, 0.2, 0.3 is low, 0.4, 0.5 medium, 0.7, 0.8 is a large magnitude effect size. It actually tells you better whether this thing that you're looking at is clinically relevant. Statistical significance may occur like if you have a very large population of very small differences, but effect size does not depend on the end. It's just how large, and these are quite good large effect sizes, both in functioning scores and also in decreasing depression rating. So I use it. I actually use it also for, by the way, for unipolar depression. Most things that work for bipolar depression also work for unipolar depression. So I sometimes use it. It's actually quite a potent antioxidant. Here we go. So again, looking at there's some traditional studies. It helps other conditions. Very little side effects. Some of my patients do complain of some GI problems. And what NAC does is really interesting. Is a very potent antioxidant. And as you know, oxidants are oxidation in the brain is not a great thing, and it impacts things like cell death or cell shrinkage or whatever. And there is oxidative stress and reduced antioxidant status is common to many psychiatric disorders, including schizophrenia, depression, bipolar, obsessive compulsive disorder, etc. So what it does, it increases glutathione, which is a very potent antioxidant, and also has been shown promise for attenuating both dopamine and glutamine dysregulation. Again, you have medication with at least one good study, can help another condition, the second condition. It makes sense in terms of its physiology, and it's actually, frankly, not that expensive and pretty well tolerated. Okay, now, does it work for everybody? Of course not. None of these things are panacea. Do antidepressants work for everybody? No. Does therapy work for everybody? Of course not. Okay, we're talking about adding something more to your armamentarium. So now in pregnancy is really interesting. So you can use it in pregnancy. And I found this extremely interesting. So it turns out that I think this study was done somewhere in maybe it was in Iran or Iraq. You can look at the reference, but patients that had recurrent unexplained miscarriages were treated with a combination of NAC and folic acid, and they were age matched. And the reason is that some people had this theory that unexplained miscarriages were associated with increased oxidative stress levels. So what they found is that 600 milligrams of NAC boosted the chances of pregnancy continuing past 20 weeks by 190%. You know what they actually people use now? Those of you who do perinatal psychiatry, what do they use for recurrent unexplained miscarriages? It's in a several patient. You know what they use? Does anybody know? Mahi, do you know what they use? Huh?
Baby aspirin. Baby aspirin.
They do that, but they also use Plaquenil for some weird reason.
Okay.
Yeah. And Nikki used to be an OB, but you know. So it turns out that, I mean, I think if I have a patient that has depression or bipolar disorder, I would probably try I'll talk to the OB and try using NAC for this particular reason. The other interesting thing is that NAC was used in women with polycystic ovary syndrome that, again, you know, they have lower pregnancy rates, and it boosted pregnancy rates by 40% and lowered miscarriages by 60%. And these are patients that were clomiphene resistant, which is usually clomiphene is the treatment for PCOS. So again, you have another way that you could use this and kill 2 or 3 birds with the same stone. Okay, so again, I call this jokingly the Paco rules. Okay, remember we're talking about studies. There's not a lot of studies, so I use all these criteria, and I said physiology doesn't make sense. Is there at least one adequate clinical trial? What is the cost-benefit or risk-benefit ratio? And does it affect other conditions? Oh, you know what? It actually, if you look at all these first letters, it's my nickname, Paco rules. You're never going to forget that, aren't you? Anyways, so let's talk a little bit about omega-3 fatty acids or fish oil, because they are the most commonly used CAM treatments in the United States. They are, and again, Nikki can speak to this. Nikki is the OB. They're clearly well-established health benefits, and particularly benefit from obstetrical outcomes and infant development. They did a study many years ago where they showed that high intake of fish oil during pregnancy decreased the chances of infants or children having asthmas and other allergic diseases. It's really interesting. Okay, so it clearly has clearly benefits for obstetrical outcomes and infant development in general. The two most common omega-3s are eicosapentaenoic acid or EPA and docosahexaenoic acid or DHA. So you're going to remember about this EPA and DHA. EPA is Environmental Protection Agency. That's what when I talk to my patients about this. And it has important implications because for depression, EPA seems to be the key. So now, clearly, I mean, there's several meta-analyses of randomized controlled trials that demonstrate a statistically significant antidepressant benefit of omega-3 fatty acids in mood overall. But at least 2 meta-analyses showed that the effective component is EPA, not DHA. The reason is that, in pregnancy, they recommend DHA. For depression, EPA seems is to work. And the doses are in about 1,000 milligram range, or, the ratio of 60% EPA to DHA. But in general, I just use the 1,000, milligram range. So 1,000 milligrams of EPA, not 1,000 milligrams of total omega-3. And I make sure that I tell my patients that very carefully. Okay, so there is something called the International Society for Nutritional Psychiatry, believe it or not, and they came out with some research practice guidelines and for omega-3. And again, they recommend that both pure EPA and DHA on a ratio of higher than 2, EPA higher than DHA, are effective. They recommend doses from 1 to 2 grams of net EPA daily. And also this expert consensus panel agreed that you can use polyunsaturated fatty acids, omega-3s, in the treatment of pregnant women, children, and the elderly, and prevention in high-risk population. Again, just to remember, EPA, think of environmental protection agency is protection from depression, and about 1 milligram of native EPA, 1 gram, I apologize, 1,000 milligrams, 1 gram of native EPA daily. So now, again, in pregnancy, again, this is an association study between low omega-3 intake from seafood and increased depressive symptoms, an association. And again, women with no omega-3 intake from seafood were more likely to have high levels of anxiety compared with those with intake of more than 1.5 grams per week. Okay, so that's in the perinatal sphere. Now, in general, to optimize pregnancy, the consensus guideline is that pregnant women should consume at least 200 milligrams of DHA. There's nothing to say about EPA. This is just for the development of the fetus. So, and it's not a lot, 200 milligrams of DHA. But even despite increased demand for omega-3 fatty acids, I mean, the fetus is sucking this thing up. Still, the dietary intake by perinatal women in the US and the UK has been noted as deficient, at least in certain groups. Okay, now I'm going to show. This is a little bit of digression because I'm showing this with the purpose because we have to be careful sometimes about meta-analysis. This is a meta-analysis done in 2019, reported in the Journal of Affective Disorder. And it included, and the good news about this thing is that, you know, is a meta-analysis. There were not a lot of studies. So you can actually, you can check the studies. The point is that this particular meta-analysis, where they look at all these studies, they found no evidence for an effect of omega-3 in reducing prenatal or antenatal depression. And it included these 3 studies. Well, you know, it's a great theory. It didn't work. Let me tell you what the problem is, and let me tell you what, again, meta-analysis are extremely helpful, particularly because you can put together a bunch of studies and increase your power. But the problem is that depending on what you include in the meta-analysis and how many studies do you include, you may have a result that is not quite as it should be. And the problem in this study is that it included this study by Morsukovic, Ellen. Actually, it was actually done here, and some people in our perinatal clinic were part of this study. Ellen Morsukovic did this particular study in using our clinic. And what they did is they took 126 pregnant women at risk for depression. See, they did not have a full depressive episode, and they assigned them to, you know, EPA-rich fish oil, like Good Dose, DHA-rich oil, soy oil. And what they found is that the EPA-rich fish oil and DHA did not prevent depressive symptoms during pregnancy and the postpartum. The problem is that, first of all, this is not a treatment study. This is a preventive study. To show prevention, you need to have really, really high numbers because you want to make sure that enough people get depressed. The other problem, though, is when you looked at, I mean, we were recruiting these people for her. There are 2 things that were happening. First of all, because they were not having full-blown depression, depressive symptoms were actually quite low. And most of these patients were actually doing also medication and psychotherapy. So what you see is that you have this kind of bottom effect. And again, this is a complicated slide, but just to point out here, for example, this is the Beck depression inventory. It's pretty low, 8, and came down, you know, to kind of 4, you know, etc. But 7. So you see the point. The problem is that you having this bottom effect because these people were not in full, I mean, maybe 1 or 2 were only depressive episodes. So it is a little bit misleading because you're not giving this to women that have a full-blown depression. So again, you get this, you know what I mean? It's like, you know, you give Prozac to people who are not depressed. There's a Prozac, it doesn't work because, you know, everybody's getting better, just a little bit dysphoric and then get better. So you get the point. So this other meta-analysis, in fact, that was done earlier did not include Ellen Morsukevic's study. And actually, I don't know why this study was not included in the other one. Kaviani was included in particular here. And they did find an effect of omega-3 fatty acids for pregnant women with MDD. As you can see here, you know, each of the studies, the kind of the difference between placebo. So again, I'm telling you this as a kind of a side trip to, you have to be very careful with meta-analysis because when multiple studies are included, I mean, if you have 1 or 2 studies that doesn't show something because of issues of design, you know, sometimes you have to go back and look at the primary data as a clinician, as a researcher, okay? So the bottom line, On the basis of positive findings from RCTs and meta-analysis in non-perinatal depression, I advise to my MDD patients to consume at least 1 gram of EPA daily, and I strongly suggest to pregnant patients with depression to consume at least 1.5 grams of EPA daily. Now, people have heard me this. I do not have any investments in Nature Made. They're not paying me anything. They should, maybe. And this is just, I mean, you can pick up whatever you want, but remember, the Nature Made are the people that send their products to USP, and you can find it in Myers. This is, I mean, you can order other things online, but I find this easier. You go to Myers, you buy it, and this is the highest that I've seen EPA. So each capsule has about 693 milligrams of EPA. You see here, and you take 2 of those, and you're in business. The other thing that I like about the omega fish oil, often in Myers, I mean, in fact, last week they were also doing the same thing. You can have, like, you know, buy one get one free. So it's about, you know, for about 3 months or something, it could be like about $30 or something like that. Actually, quite remarkable. So I like it. It's easier. It's a good product. You can get it in Myers. And some of my patients are rating the darn thing, so sometimes it's hard to find them. But again, it's, you know, it's one of the things where, again, the risk is very little. The only problem that I had, of hundreds of patients that I treated with fish oil, just to let you know, I mean, omega-3s are, I mean, they're anti-inflammatory. That's one of the potential mechanisms. They also seem to change the membrane composition, the fatty oil membrane composition. Maybe some people think it works that way. They also are mildly anticoagulant, by the way, very mild. So I had one patient that she had this weird kind of a genetic coagulation thing, and she developed bruises with fish oil. We stopped it. But in general, I mean, you know, very, very, very easily tolerated. So almost, and I will have to say, almost all my patients are taking fish oil. I don't know if one of my patients is here. We can talk about that a little bit later. That, I mean, some people, again, this particular patient, she had gastric bypass, and that's, you have to be careful about that, because for gastric bypass you have to increase the doses, and she was taking pretty high doses. She backed up on the omega-3, and she developed depressive symptoms again, and she went up again higher, and just doing quite well. So I don't know if she was able to join or not, but I mean, again, for whatever it's worth. Does it work in everybody? No, but I think it's a no-brainer. Now, in general, let's talk a little bit about micronutrients, you know, like, you know, vitamins, trace minerals, trace elements. You really need more of them in your daily diet than you think. And these are extremely important for the way your brain works, the way your enzymes in your brain works. They're extremely important for not only brain health, by the way, but the health of your whole body. Now, this is one of the, I found this, in fact, you know, fascinating, this particular study about, you know, micronutrients. There was an earthquake in New Zealand. It's high 6.3 earthquakes in Christchurch, New Zealand. And this particular researcher, and this actually, I think she has a TED talk too. You know, you could think, well, there's a huge stressor happening, and my intervention would be, let's just give him, you know, everybody has to intensive therapy right away to see whether it decreases the rates of PTSD, of depression, etc. What this particular person did, or this particular research group, they actually gave some people high doses of micronutrients after the earthquake. And what happens is, when they follow them, the patients that used these micronutrients reported significant lower levels of anxiety, depression, and PTSD symptoms. And the benefits were sustained at 1 year follow-up. I actually find that remarkable. I would never thought to do that. So, you know, it's just like, you know, I mean, maybe because after a catastrophic event like that, people have fewer access to good food, or because stress itself depletes your stress can deplete your vitamins and your trace minerals. And in fact, there was a flood in Calgary in 2013, and the similar results were found with supplementation of micronutrients. So, I mean, you know, again, I find that remarkable that, you know, doing this thing after a quote unquote stressor helps, you know, helps the rates of depression, anxiety, PTSD, etc. Now, let's talk a little bit about folate. You know, it's an important, you know, vitamin, right? And again, it is recommended in general that women of reproductive age consume 0.4 to 1 milligram folic acid daily during pregnancy to reduce the risk of neural birth defects. But again, depending on some populations, you have to be careful. I mean, we, in Ann Arbor, in Michigan medicine, we're pretty good at it. And I think this has actually changed. It's a little bit older study, but certainly in a pre-correct study of non-pregnant women, less than 6% of women who became pregnant during the observation period reported daily folic acid supplementation of 0.4 milligrams per day or more. Again, usually our OBs are pretty good at it and they catch it right away. But in general, most women of reproductive age are not walking around taking folate. Now, there is clear, again, an association. Most, although not all studies, report an association of low folate levels and an increased risk for depression. More importantly, though, and again, there is a difference between risk for depression and ability to respond to an antidepressant. I think that the data is fairly clear that low folate levels are associated with a poorer response to treatment with an antidepressant in major depressive disorder. This is outside pregnancy. I think I'll show you why in a second. So, for example, this is a really interesting study where they did a placebo-controlled trial and used folate as an adjunctive treatment to fluoxetine, and a significantly greater improvement was seen in the folate group. Then, I don't know, you guys use this a lot. I kind of use it, but not a lot. There are two multi-center placebo-controlled studies that used L-methylfolate, which is Deplin, which is approved for quote-unquote treatment, treatment refractory depression. And they, as an add-on with antidepressants, and the improvement was found with a 50 milligram dose, but not with the 7.5 milligram dose, for whatever it is worth. Now, there's a difference between folate and methylfolate, and I'm going to talk about that in a second. Yes, so one of the things that we need to think about is that, folate, to be able to cross the blood-brain barrier, folate needs to be metabolized into L-methylfolate. And it's, for a complicated neurochemical reason, it's thought to help stimulate production of neurotransmitters, etc. Turns out that some patients have an impaired ability to fully metabolize folate, things like age, medication, nutrition, all the health-related factors. So they may not get folate into the brain, okay? And in fact, there is this polymorphism of the enzyme that converts folate to methylfolate. And many people, in fact, have a compromised ability to do that. So that is why, in general, I recommend people to use methylfolate as opposed to folate, okay? What I usually do, though, is in general, what I do is I try to recommend people to increase their dietary intake of things that are really, really dark, that have both folate and methylfolate, like, a spinach, kale, avocado, whatever. So I try to do it nutritionally, but occasionally I do methylfolate. Now, this brings an important, nobody's done this study. If somebody would give me money, what I would probably do, you can actually take a prenatal. Usually prenatals have folate, but some prenatals have methylfolate. It will be so interesting to take a group of women, pregnant women with depression, and randomize them to folate and methylfolate, in their prenatal vitamins, and give them antidepressants, see whether they respond better or not. Again, based on this, I would probably think that would be the case. But again, just to show you that it's important to know the neurobiology of these things. Now, let's switch to vitamin D, because vitamin D is a big issue in Michigan. Well, in many places, right? But, because even though Michigan is very sunny all year round, et cetera, et cetera. Yeah, kidding. So it has been estimated that about a billion people have either vitamin D insufficiency or deficiency, okay? Now, deficiency is defined as levels less than 20 nanograms per ml. Insufficiency is level less than 30 nanograms per ml. So you have, when you order a level of vitamin D, you have to look at, because if it is like 30, 20 something, it's not going to come out with that, what, at least in our system you get the exclamation point. But if it is less than 30, even low 30s, I don't like it. I tend to supplement them. It's a little bit different how you supplement it, because it's very deficient. You got to give high doses of vitamin D, like 50,000 a week for 10, 12 weeks. If it isn't sufficient, you can get away with 2,000, 4,000, and you follow the patient, okay? Now, Vitamin D clearly has an impact on multiple disorders such as cancer, osteoporosis, diabetes, cardiovascular disease. In fact, my wife is a pediatric endocrinologist, and some of their colleagues, also in women, Dr. Josephine Casabubu, who's a director of the adolescent PCOS clinic, they check vitamin D routinely, because it has been shown to help with diabetes control. Okay, and of course we know that lack of vitamin D, particularly in women, but in everybody, low vitamin D increases the risk of osteoporosis. So it ain't good to have low vitamin D, not good. And I often look at the patient, and for example, if they're using a head cover you have, if they're too dark or brown like me, or if they're actually too white, and I ask them how much you spend out in the sun. Unfortunately, even when it's sunny, our friends, the dermatologists, want us to, cover ourselves to decrease the chances of skin cancer. So, I mean, it is actually quite prevalent. I order it, and as my residents know, I mean, those of you who do it, I think we maybe like, I would say like 20-25% of the people that we order has at least insufficiency, right, Andrew? I think that's our experience in some of the patients. I mean, most of the people that I supervise, they do this routinely, and you see at least insufficient. So now, again, there is a correlation. Depression itself, if your body has depression by definition puts you at risk for low vitamin D. It's linked. Low vitamin D is associated with depression. Again, it's an association in young women of reproductive age. Is low D levels also associated with perinatal depression, and also depression in adults in general. Okay, so for me, a diagnosis of depression puts somebody at risk for low vitamin D for multiple reasons. I mean, we don't know why. Maybe you're depressed, you don't go out in the sun because you have low motivation, low energy, you don't have a good nutrition. That's clearly an association. So again, it is a risk factor for low vitamin D. Now, does it work if you give vitamin D or not? And again, you have to be very careful, because many years ago, I was pushing for vitamin D, give vitamin D to people. This meta-analysis came and it showed, what? Clinical Endocrinology, which is a respected journal, it failed to show an effect. However, when you look at the study, they picked up many studies who focus on individuals with relatively low levels of depression. Remember, we talked about that before. If you have very low levels of depression, something that has an effect, you're going to have a floor effect. You're not going to see statistical differences. The other thing is that they actually picked up people that, had normal vitamin D levels, that doesn't do anything, right? So, and then their studies use varying vitamin D doses, duration of treatment. So someone came and says, well, you know what? What I'm going to do is I'm going to look at the studies without flaws. That is, studies that control for low vitamin D levels and for depression. And they, in fact, show a significant improvement in depression with vitamin D supplements. And look at the effect size. It's actually quite a respectable effect size, 0.78. I mean, it's actually as good, or I mean, certainly better than antidepressant. Now, these are in patients with low vitamin D. So again, patients with low vitamin D, they have depression. A significant number of them would actually get better. Now, that doesn't mean that depression is caused by low vitamin D in everybody. The way you should see this, and the way you should see this as a neuroscientist, is that, again, there are multiple factors affecting your brain. Some of them are 4 or 5%, some of them are 10%. And, this particular thing may tip you over the edge, right? And like low intake of omega-3, low vitamin D, trace minerals, whatever. So correcting those things in some people is going to work. Does it work with everybody? No. As I said, do antidepressants work with everybody? No. Does psychotherapy work with everybody? No. The other thing is that there's vitamin D and 1-alpha hydroxylase, which is the enzyme responsible for vitamin D conversion in human brain. It's in the brain, ladies and gents. It's in the brain. So if it's in the brain, it must be doing something in the brain, okay? So now, all these came out, and then about 2 or 3 years ago, there's this huge trial called the VITAL study. They did multiple things. They look at diets of people. They look at medical outcomes. And MedPage, which is, we all get the MedPage emails. The headline was, really, this is the study that showed that there are no mood benefits for vitamin D in this vial trial. Again, I looked on the study and I actually wrote a comment in Med page, which was actually partially edited, because what I said is, listen, first of all, this study was not designed to investigate whether rectifying vitamin D deficiency in patients with depression, decreased depressive symptoms. In fact, there you go. Patients who had depressive symptoms at the baseline were actually, in fact, excluded from the study. And then most subjects in the study had adequate vitamin D levels anyways, and the dose was actually modest, 2,000 international units. I actually wrote my thing, the first thing that I say is like, this is a very misleading headline. And then I wrote this, these comments. They didn't like it, so they took away the first line that says this is a very misleading. I was censured by. They wrote my reasons, but they didn't like the misleading headline. But it was a misleading headline. Again, you have to be careful. Even if you're a clinician, even if you don't do research, you got to look beyond the. You would expect people who write these things may or may not be physicians, but you have to. You got to read the fine print in all these in all these studies. It's extremely important. So now, this is actually, in fact, the most recent, well done, randomized meta-analysis of randomized vitamin D control trials. Now, you have to remember, they looked at everything. That's actually well done. Now, so the conclusion, again, and they looked at studies of people that had depression, people that only had mild symptoms, etc. When they looked at all the studies, their conclusion is that, taking at least 2,000 IUs of vitamin D per day actually helped ease symptoms of depression. The effect size, it's small and reasonable. It's actually, that's kind of the antidepressant effect size, more or less. However, they have a beautiful table. When you look at this study, if you look at the studies, or the subset of studies of people that had full-blown diagnosis of MDD, and there are 7 studies, more 500 patients, 500 controls, 600 controls, then you see that a remarkable effect size. Look at this. So if you diagnose with MDD and you have low vitamin D levels and you give supplementation, it's a negative effect. It means that, people are getting better, the decreasing depressive symptoms. The effect size, look at in this, again, it's a little bit unfair, because this is the very famous Lancet study where they look at this meta-analysis of a bunch of antidepressants. This is antidepressant as a whole. Some antidepressants work better than this, but look at the effect size. It's as good as psychotherapy, better than antidepressants. So, man, I'm telling you, if you got somebody with MDD and low vitamin D and you're not supplementing them, you're not practicing good medicine. Okay, that's just the point. This is, for me, it's certainly clear, right? So, I've been on the mission from this for years about this stuff. I think it's picking up. Sometimes now we're seeing people coming from the OB clinics with little vitamin D. Now, anyways, so how about in pregnancy? Now, there was a study. Usually it's very low vitamin D. You have to do like 50,000 orally a week for 10, 12 weeks, and you measure it again, whatever. Can you do that in pregnancy? Well, they did this very interesting study where they were looking at vitamin D supplementation in pregnancy. And turns out that women who took relatively high doses of vitamin D during pregnancy had reduced risk of complications, including gestational diabetes, preterm birth, infection, etc. In this particular study that I reference here, women took as much as 4,000 IUs of vitamin daily in their second and third trimester. So with no evidence of harm for the baby or for the fetus or the baby for the mom. Okay, so at least 4,000 is safe in pregnancy. Now, interestingly, what these investigators did, that they measure vitamin D levels in the cord. And what they found is that, some women were more compliant than others. There is an inverse relationship with any comorbidity of pregnancy. The higher vitamin D levels, the fewer events, perinatal, comorbidity issues of, in pregnancy. So again, this is, for me, is actually a no-brainer. So what is the bottom line? Well, you listen, of course, treat vitamin D deficiency, even if it may not have a psychotropic effect. Yeah, that makes sense? Okay, we can take some pictures at the end. Now, very quickly, trace elements, trace metals. don't have time to look at all this, but again, this could be another lecture. There's certainly credible links between nutritional deficiencies and mood for things like calcium, iron, selenium, magnesium, zinc, etc. Now, during pregnancy and lactation, the nutritional requirements are increased. So in order to adequately support fetal and infant growth, you need to supplement. Now, the reason that women during pregnancy take prenatal vitamins is because the nutritional demands are so high that just eating good food ain't enough. So that's why women need prenatal vitamins. Actually, in the during lactation, it's kind of the same thing. I mean, you need. I mean, there's a significant increase in demand for vitamins and trace minerals. And I remember I told you that trace minerals, trace elements play an important role in the way your brain works. So, I mean, as a rule, we're seeing that more and more now. Even, most women continue taking prenatal vitamins postpartum, and I recommend, once you finish your prenatal vitamin, pick up a multivitamin that has trace minerals, trace elements. So I'll give you a quick example, just zinc, because I for some reason I like zinc. And there's reasons I don't have to talk, I cannot talk a lot about zinc, but it has to do with the fact that zinc is part of the zinc is a component of the receptors in the brain that control the stress response cortisol. I mean, literally, they're zinc fingers. Anyways, and Parish Patel and I, very early in our careers, thought about doing something with zinc. Turns out that there are some randomized controlled trials that demonstrate that if you add on zinc, if you supplement antidepressants, drug treatments with zinc, you have a better response. And again, look at this is a study, a placebo-controlled study with add-on zinc. Look at the effect size, 0.67%. Now, is this only true for people with zinc deficiencies? I don't know. Maybe, maybe not. My personal opinion is that, zinc is in the same family, is a cation as lithium, right? And that lithium can be used as augmentation. I suspect that some of the same mechanism why zinc and maybe magnesium works, but not sure. Anyways, I sometimes, sometimes Depakote, valproic acid causes hair loss. And you can use biotin, but you can also use zinc, and zinc helps with hair loss. So I have patients that I give them zinc just because they had hair loss. And again, I mean, when I started doing this, like the first 2 or 3 patients, like great response. Then 3 or 4 patients more didn't do anything, so I kind of dropped it. And then some of these studies came. Again, does it work with everybody? Of course not. Does it work in some people? Sure. Does antidepressants work on everybody? Of course not. Therapy works on everybody? No. Again, it's something that you may want to try. And again, I don't mean to say, just before I forget, it's not that you do all these supplements at the same time. I'm just giving you tools that you can use and what things you use, and you have to use it sequentially, and you have to use it judiciously. Okay, I'm just giving you all this information of alternatives and things that I try fairly frequent. Okay, now for pregnancy. Again, there is usually no need to screen pregnant women for trace element status, except, you check hemoglobin, hematocrit. However, if you need to do a good history, I mean, the best indicator that a woman's trace elements is maybe a risk is a history of poor food selections, which you see, for example, in certain countries, but also in some of our poor communities and immigrant communities. So so you have to be you have to be aware of it. And so be suspicious. At least, I mean, some people do like hair samples and stuff like that. I like to do it. I think a history is enough. Now, this is the problem, ladies and gents, is that we usually in general get our trace minerals and trace elements and trace metals through food. In fact, some of the same foods that are rich in folate acid have trace minerals. We get it, but they get it. I mean, these vegetables, they get it from the soil. The problem is that our soil, I put this title as a kind of a, be provocative, but our farmers, they need to survive. So sometimes they need to farm again and again. So over farming causes decreases in rates of trace minerals, trace elements in the body. It's been shown. I mean, and not everybody. I mean, if you're living in a poor community and you're a single mom with 3 kids, you ain't gonna go to an organic food place that costs much more, it's much more expensive, right? I mean, if you can afford it, you go to whatever, organic market, but often you cannot. So, it's a problem. That's why I routinely put everybody on a multivitamin with trace minerals, trace elements, okay? So, again, just to be provocative, this is the recommendations for prenatal vitamins and WebMD. 400 micrograms of folic acid. Look at how much vitamin D they recommend. 400 IUs. That's not enough. It's not enough. And certainly for there's no recommendation for EPA, some for DHA. Again, you may need some of the women that we see. I made a point of supplementing them, either vitamin E, vitamin D, certainly fish oil, and and again, the question of methylfolate is, depending, really, sometimes I do, sometimes I don't. So now we're good, man. So I'm sorry. I know I talk a lot and I want to give you a lot of information, but as I said, I want to give you this base so that you can go back and look at the studies and then make your decision. Let's talk a little bit about adaptogens. What the hell are did I cuss? Oh, what the hell? Oh, who cares, man? So what are adaptogens? As the title would imply, adaptogens help you adapt. Is a term that is used for herbs, roots, or other plant substances like mushroom that helps our body manage stress and restores balance after a stressful situation. Now, we that work in the mental health field are stress clinicians, right? We either deal with the impact that stress is having in people's illness, but the illness itself is a stressor. And the stress response is very complex. It's both, you have this increase in neurotransmitters and stress hormones. I mean, this is a very, very broad. I'll go back a little more into details about this because this is important about adaptogens and about the way that I visualize, that I think about chronic recurrent mood disorders. But anyways, we know that the stress response causes, this is actually, in fact, to show that there is this organ here on top of the kidney called the adrenal, or it's just also called the suprarenal, that may mediate some of the effects of stress. And stress can cause multiple changes in the brain. So let me talk a little bit about this stress business. Now, I'm going to talk a little bit about, again, this is not the only system that responds to stress, but this is what's called the hypothalamic pituitary adrenal axis. This is actually the classic neuroendocrine system that responds to stress. Okay, it's a little bit complicated for those of you who know medicine, but the point is that upon perception of a stress, your brain, actually anybody's brain, including this actually turns out this is a rat brain. This is from a very old article that we did many years ago, but the perception of a stress causes the hypothalamus, or this area of the brain, to release these factors into the pituitary, goes into the circulation. Remember, the adrenal, the suprarenal on top of the kidney, releases glucocorticoids, cortisol, mostly in humans, and rats is corticosterone. And this is the classic stress hormone. This prepares you for flight or fight. Now, this is a system that it should be geared, it's an alarm system, and it is geared to have an acute response to stress. So in general, because it's geared for emergencies, you don't want this baby on all the time. So what happens is that, and I forgot to put the negative here, usually cortisol under normal circumstances controls its own release by negative feedback. Tell the people, okay, you know what, don't do this anymore. The hypothalamus, don't do this anymore. And actually, in fact, there are areas of the brain like the hippocampus, which is part of the limbic system, the emotional brain, it says, you know what, stop secreting cortisol. Okay, that's under normal circumstances. You have this negative feedback loop. You see, you see a lion, or you see one of the supervisors that you don't like, and then you get a stress response. And in general, you want to shut it down. Now, a couple of things to remember about this is that these are the final products of the HPA axis, cortisol, stress hormone, now, an important thing to remember is that the brain is a target for glucocorticoids. These things are not inert. Not only do they have cortisol, not only does it have an effect in multiple places in your body, but it actually has an effect in your brain. And we and others have shown, for example, that it can change the number of receptors that you need to for antidepressant response, changes monoamine receptors. It sometimes causes shrinkage of certain brain areas. dendritic atrophy, a bunch of things that are not that great if you keep it up. Okay, so important to remember that. Now, HPA overactivity is a well-documented phenomena in major depressive disorder. Well-documented, okay? And people like our group and other people have done that. By the way, I call it LHPA. We usually, in our group, we will call it instead of calling the hypothalamic pituitary adrenal axis, we will call it the limbic hypothalamic pituitary adrenal axis, to acknowledge the fact that there are limbic circuitry, like emotional brain circuitry, that is targeted by glucocorticoids, but they also control the stress response. Now, this is what happens in depression. Many years ago, like Elizabeth, the late Elizabeth Young and I, and Watson and Akil and Uni Weinberg, we did this study. This is a classic lab stressor. This is like it's called the Trier social stress test. It's a lab stressor where you get a person in the lab in a room. You put the IV. You measure the core levels to a psychological stressor. The psychological stressor is it's like a public speaking interview. Everybody gets a response. Now, this is what happens. Now you get into the lab. This is a normal controls or non-psychiatric controls. You get a little bit of a high core because you're poked. Then you wait a little bit. It goes down to baseline, and then here you do the public speaking. You go up and then you go down again. Look what happens in people with depression. This is the same stressor. The same, we don't change the paradigm. What happens is that patients with depression, they start high, baseline core is high, they still respond, they don't shut down as well. So the area here under the curve is dramatically higher. What that tells you at a very simplistic level is that we know this, those of us who do therapy, when you are depressed, not only do you have an enhanced cognitive response to a stressor, but you also have an enhanced physiological response to a stressor. This is what I tell my patients. The same stressor that if it hits you when you're depressed, you're going to have an enhanced physiological response. And remember, I told you, it ain't that good for your brain, right? So, this is kind of a wear and tear. This is, by the way, one of the wisest things that one of my mentors, Dr. Huda Akil, a scientist, she's also in the Department of Psychiatry and the Molecular Neuroscience Institute, or it's now called the Michigan Neuroscience Institute. She told me something very early that it makes sense. Is the disease itself changes the brain, right? You can start with X or Y, serotonin or norepinephrine or whatever ketchup, but this wear and tear in the brain, makes it very different from when you started. That's why it's hard to treat chronic depression, right? So again, cortisol can affect multiple systems. That could be one of the mechanisms why people with depression have more morbidity, higher mortality, illness. It can affect your heart, can affect your immune system. Health can affect your brain. Important thing, okay? Again, the brain here ain't the same. Again, it makes you think how, and that's why I got into this business. How the hell can we, how can we heal the brain? Because the patients, these patients, that the chronicity predicts chronicity. The longer you're ill, the harder it is to treat because you have all these changes. And then again, you can imagine you get heart disease, your blood pressure goes high, more stress, on and on and on and on. So that's an important thing. And that's why, adaptogens may be important. By the way, we know that therapy can also decrease the levels of stress. So why it's so important to combine medications and therapy. Now, I want to make sure, I don't have time to do this. Do yourself a favor. Read this review that was done by Bruce McEwen and Huda Akil. It came out in the Journal of Neuroscience it's called Revisiting the Stress Concept, Implications for Affective Disorders. Huda, as I mentioned earlier, Huda and Bruce were the two top stress scientists in the world in history. Huda's been my mentor and my friend, and she, as I said, she's in the Department of Psychiatry and also professor. She was the co-director of the Michigan Neuroscience Institute, and Bruce passed away maybe a year or two ago. One of the smartest, nicest, kindest people in the world. We missed them a lot. Smart freaking people. Some people think that they're smart, and these people are. And they're kind and they're wonderful. So sometimes some of people, including our department, they think. Anyways, but great. It's accessible. It's about the neurobiology of stress and its implication. But if you treat patients with mood disorders, I think this is a required reading. So read it. You should read it anyways. So let me talk about one of these adaptogens, L-theanine, which is an amino acid. By the way, where you get L-theanine from? You guys know what thing has L-theanine? That's actually fairly common. You guys know where L-theanine comes from? It's a you know
in
what?
tea.
Pardon me?
In tea.
Yeah, it's very good. Green tea, green tea. L-theanine has in some mushrooms too. Turns out that studies have shown that L-theanine improves relaxation. I mean, again, I don't have time to go into all these mechanisms. It seems to also inhibit excitatory neurons, improves quality of sleep. Now, I mean, you got to take a lot, depends on how much L-theanine is in green tea. I mean, you can get away with drinking a lot of green tea, but, you can buy it as a supplement too. Now, interestingly, and this is what is called an adaptogen, and that's what I like about this business, is that L-theanine also seems to block the sympathetic nervous system response to stress. And there's a study also that it shows, look at this. This is actually, if I remember correctly, and I apologize, I should have double checked this, read so many stuff that it gets all this confused. I believe that this is actually after the trial social stressor, placebo versus L-theanine. As you see, I mean, there is a significant increase in cortisol after the stressor. If you pre-treat with L-theanine, you block the stress response. Amazing. Yeah, I mean, it decreases stress. That's why I actually use it a lot. Now, one of the things, and again, I apologize, it's kind of barely see these, but these are like L-theanine. These are different measures of sleep, increases sleep quality, sleep architecture. So it's helpful for sleep. So one of the things that I do sometimes, instead of giving somebody trazodone or a benzo at night, I usually try this first, and you can get a Nature Made melatonin plus 200 milligrams of L-theanine, and you can do 1 or 2 capsules. The only thing that I don't like is seem to have a little bit of a short half-life. After 4 or 5 hours, I'm kind of awake again. But melatonin may not help with insomnia. You can actually get L-theanine by itself, by the way. Okay, or you can drink a lot of green tea. Now, one thing about L-theanine is that it has not been studied in pregnancy. However, I actually found out, so, I would not recommend it to pregnant women, but, or women that are breastfeeding. Turns out that green tea, the guidelines, and Nikki may correct me if I'm wrong or not, but if I remember, the guideline is that women can actually drink as much as 3 glasses of pregnant women safely of green tea during pregnancy. So maybe an indirect way of asking our women to, drink a green tea, right? But a very interesting adaptogen, so to speak. Again, what I found is that, some of these things, they decrease the response to stress. Now, another one that I use a lot, and some of the people in perinatal have seen me use this, certainly postpartum, in non-breastfeeding women, but I always use this before I put anybody on a benzo. Okay, ashwagandha or Withania somnifera it's been a staple of Ayurvedic medicine for hundreds, thousands of years. And there's been some studies that for example, in this part, I picked up 2 studies. Again, there's not a lot of studies, but what's there, it's pretty good. And in this particular study, in the first one, they used 250 or 600 milligrams of ashwagandha for 8 weeks and significantly reduced perceived stress and also reduced the levels of cortisol. The other thing is that it improves sleep quality. And in another study, they used only 240 milligrams per day. And it also caused significant reductions in anxiety. What I find, I use it myself, I tell my patients, what I find is that it doesn't make you sedated. What it does, it seems to decrease especially at night when I take it. By the way, these studies were done like twice a day or something like that. I have found, and I told my patient, you can also use it as needed, and it works the same. And what it does, it seems to decrease the physiological stress response and allows your mind to kind of settle down a little bit, and it doesn't make you too sedated. You still have to be careful, but in general, it doesn't. So I, as a matter of fact, always start doing this before benzos, and more often than not, it's enough. So let me show you from that second study. Just focus on cortisol. Look at how significantly the decreases in cortisol were 60 days after ashwagandha, and this was accompanied by stress decreases in stress perception and decrease in anxiety. DHEA, I don't want to go into this thing because DHEAS is also secreted by the adrenal in conjunction with cortisol, so it goes down. The good news for people like me who are older is that it does not decrease testosterone level. So that's good, all right? Seems to be specific. Now, so again, I use it all the time. Now, what I usually do, I don't forget, you know, I do the Nature Made one, and what I do is I recommend 1 to 2 capsules twice a day. I don't do more than 2 capsules twice a day. You can do it acutely. You can do it at night. Some of my patients, you know, usually if you wake up and you take it at night, it may take about 1.5 hours to get absorbed, 1 hour maybe. And then, I mean, again, you'll see. Remember, you know, once you wake up, especially for anxiety and insomnia related to anxiety, is that you wake up and you start thinking about things, or your patients are thinking about things, and increases your stress levels, and then it fits into your negative thinking. This seems to, again, does it work in everybody? No. But I'm telling you, it's easy to take, not very expensive, very little to no side effects. Again, my recommendation is that you should use it before trying a benzone, you know? So now, other supplements, just to teach you, we don't have time to do this. We were talking earlier about Celexa, lavender, a lot of literature now. We don't have time to go through that. L-lysine and L-arginine for anxiety. Acetyl-carnitine, I actually use a lot, particularly for geriatric depression, diabetic neuropathy. DHEA, the dihydroepiandrosterone, works for depression and anxiety. By the way, you know what? All the thing that DHEA does is that if you have an elderly patient, and you know that when you get older, you get sarcopenia. Your muscles get weakened, and then it puts you at risk for falls and things like that. They did a study. So if you give the HEA on their baseline condition, it doesn't do anything to your muscles. But if you start working out, you do strength training, and you take the HEA, it increases significantly your muscle mass compared to in training alone. So sometimes I give it to my older patients that have depression, or even younger patients, you know, depression, and because the HEA seems to have an antidepressant effect too, and I don't have time to go through the data. Magnesium for sleep. Also, I mean, we don't have the whole lecture about the gut-brain interaction. Some probiotics have been found to be good for depression. Oh, I forgot to ask you. I'm going to tell you a story about ashwagandha. I forgot to tell you because, again, you know, it's one of the things. I mean, it is you know, one instance, but I've been seeing a physician colleague who had significant trauma related to the birth of her baby, and I mean, they really mismanaged her, and she developed PTSD, anxiety, some depression. Came to the clinic late. We got an antidepressant. We, you know, tried benzo. She didn't like it. We tried other things. Eventually, I put her on ashwagandha, and she emails me and says, "Paco, thank you for putting me in ashwagandha. It has significantly decreased my anxiety, and not only that, it has actually helped my bonding with my baby because, of course, the anxiety was interfering." Again, doesn't happen with everybody, but I mean, once in a while you see these things, and I mean, I think again, it's a no-brainer. Now, let's talk about the Wonder treatment that reduces depressive symptoms, improves anxiety, decreases the risk for Alzheimer's and cognitive impairment. It improves insulin sensitivity. Sensitivity has a positive effect on myocardial function. Unfortunately, it's not covered by insurance. What is it? Caitlin, since you were smart enough to tell me, what do you think is a Wonder complementary treatment that does all those things clearly? Anybody? What do you think?
Is it exercise?
Damn right. Exercise. It's not covered by insurance, but it's freaking free. It is free. Now, listen, no way around it. No ifs, ands, or buts about it. Exercise has a large and significant antidepressant effect in people with depression, including MDD, okay? Very quickly. Now, most of the early studies were done with aerobic exercise. Clearly reduces depressive symptoms. Now, not only in, you know, the depression, even in, you know, both antenatally and prenatally. Now, this particular study, which one of the earliest one, they looked at women without MDD, and showed that both exercise and general physical activity was associated with fewer depressive symptoms. Okay, so they were measuring depressive symptoms, but they were not full-blown MDD. Now, I want to show you this because this is just came out. And you should look at this study. And this is the most recent review. This is physical activity interventions in general for improving depression and anxiety and distress. This is what's called a umbrella review. It's a review of multiple reviews, and they looked at the data, et cetera, et cetera. Now, in this particular study was really interesting because they look at physical activity as a whole. They looked at, you know, people moving around, They looked at aerobic exercise, they looked at yoga, they look at multiple different activities, okay? Now, so, and it included interesting, I mean, all these studies were done, I mean, all the studies that were done, both healthy adults, people with mental health disorders, people with various chronic diseases, okay? Important, right? Remember, we talked about the medic interaction between chronic diseases and stress on the brain, etc. Now, in general, when you look at all physical activities, that includes everything, right? You know, walking, aerobic, you know, weights, etc. Any physical activity had a medium effect on depression, effect size 0.43, still better than antidepressants, by the way. And also an effect in anxiety, positive effect in anxiety, 0.42, about the same. And also an effect in psychological distress in general. If you're stressed about things, you have psychological stress. In fact, the effect is a little bit higher. Now, interestingly, and again, there's a lot of subtleties and different things that they did go look at the study, but the largest benefits were actually seen in people with full-blown depression, with HIV and kidney disease, and interestingly enough, in pregnant and postpartum women and healthy individuals. So, I mean, it's actually pretty cool. Now, there is something interesting that I think I'm going to change a little bit the way you see the exercise. They did multiple analysis, depression, mild depression, anxiety. They actually looked at the effect of depending on the exercise mode. Okay, so basically, they looked at what is the effect size for strength-based interventions, right? You know, strength training, right? Mixed mode interventions, things that combine, you know, a little bit of weight, a little bit of aerobic, stretching, yoga, other mind model activities, and aerobic exercise. This is what I find amazing, and this has actually altered the way that I recommend exercise. For depression, what this tells me is that strength-based exercise alone has a significantly depressing mood, okay? Weightlifting, yeah. Hell, I mean, I've been doing weightlifting for about 9-10 months now just to combat my sarcopenia. I feel better. I mean, maybe there's a little bit of aerobic involved, but I mean, again, stretching works, yoga works, you know, aerobic exercise works. Now, this was not statistically significant subgroup, but look at this. I mean, I now routinely ask my patients to add strength training to exercise for multiple reasons. I mean, only because of this, but you know that particularly in elderly people, you know, as I said, you know, sarcopenia occurs, and you're more likely to fall if you have low muscle mass and things like that. I gotta tell you, when some of you who do geriatrics, you know that if once an elderly patient falls and breaks his or her hip, their hip, it's terrible. I mean, they don't. I mean, I mean, sometimes it's a kiss of death. They don't mobilize, start having all these problems. They get more depressed. It's a problem. So I stress muscle training since early in people's lives. I mean, I don't see any adolescents, you know, but you know, I see many of my patients have been with me forever. So I always, the other part of it is that for osteoporosis, you know that muscle strength training increases bone mineralization. Can you imagine, you know, you're not lifting weights, you're depressed, you have low vitamin D, you have high core levels, you know, terrible, right? So again, and you know, interesting for anxiety, some of the things were not as significant. The significant one for anxiety, the big one seems to be stretching, yoga, and other mind, which makes sense. But you know, again, so maybe for anxiety, I mean, I certainly recommend everybody to do exercises, right? But I think, you know, if I were to pick up something, I'll probably speak like yoga, stretching, and other mind-body modalities. That makes sense. Okay. Again, you know, I'm going to talk a little bit about prenatal, but can you exercise when you're pregnant? You're damn right. You got to be careful. Again, this particular study showed supervised exercise 3 times a week during most of pregnancy show significant differences in these depression scores compared to women that were depressed, and also the percent of women that improved. So, I mean, you can do it, okay? During pregnancy, you have to be careful. Now, check this review, which has to do with exercise in pregnancy. The bottom line is that it says spotlight on the fetus, how physical activity during pregnancy influences fetus, etc. The point of the bottom line of the study, when they looked at all these studies, I mean, it's a 2020 review, is that in general, neither low-key, moderate maternal physical activity nor relaxation techniques were observed to have a harmful effect on the developing child. Okay, so you can exercise, just be careful. Now, the other thing that I, not only in prenatal, but, postpartum, exercise works, right? And again, there are 2 randomized controlled trials comparing 12-week intervention exercise with a control situation, and you get significantly greater reductions in EPDS. In Edinburgh is a scale that we use in perinatal psychiatry for depression. Interestingly, you can say, but you know what? I mean, I'm so tired. I'm a new mom. Lopez, you're crazy. I gotta feed my baby. Da, 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 da. Turns out, they did this study. Exercise can actually reduce physical fatigue. I'm not sure. I mean, I think it makes the sleep better or something. I mean, certainly, as an add-on treatment, I tell the women, you know what? Get your baby carriage, just push a darn thing and do some power walks or something like that. It works. Again, it works for depression, works for anxiety, prepartum, postpartum, outside partum, men, women, children. I mean, I don't have any children, but you should talk to Todd, child psychiatrist, that has this amazing, is very into exercise and nutrition for adolescent and kids depression. It has an effect. So anyways, should we recommend exercise? Well, duh, shouldn't you, right? So let me submit to you again. Let's go back to this business, and I think that we need. I mean, so I hope that I show you that this particular quote unquote lifestyle and nutritional interventions have positive impacts that are good or better than some of the things that we use, like medication and psychotherapy. Certainly, as an add-on, there are no-brainers. Sometimes they work by themselves. So I think it's our role as physicians or as mental health workers. I mean, some of the exercise and nutrition, anybody can do it. Is it easy? Is it easy? No, of course not. I mean, you have no energy, you got no motivation, but we're doing therapy. I mean, that's part of your therapy, mobilizing people, right? Behavioral activation, motivational interviewing. I mean, that's your role. I mean, I think that we're making a disservice because primary care physician, you should do more. We are the ones, particularly in our psychiatric population, that we need to address these things. We need to intervene, okay? And we need to use them because they freaking work, okay? The old adage I never heard before in Latin, mens sana in corpore sano, a healthy mind and a healthy body. What's good for your body is good for your brain, and it's good for your mood, okay? And vice versa, right? Fair enough? So pay attention to your patients or your clients, or whatever you call them, diet and exercise. It's just good clinical practice. And I don't mean to say, listen, somebody says, Dr. Alcorn, my husband is cheating on me and he's not paying attention. I feel so bad. I say, oh yeah, go do exercise. That's not the way it works. No, the way you frame this is that, listen, this is a stressor. And yeah, you talk about the husband, things like this. But what you said, all these stressors are affecting your brain. And we want to make sure that we treat you so you're able to treat, to deal with this better. Right? I mean, this is part of overall. Listen, you have to do self-care. It's important for you. I also told you that when you are in the middle of a depressive or a mood episode, your response to stress is larger. You guys know that, right? I mean, sometimes when people have very severe depression, one of the things, for example, that one of my patients was telling me yesterday, he had treatment refractory depression. He was using intranasal ketamine. He's been doing therapy for a while. That the ketamine now allows him to be able to kind of use his resources to be able to integrate the therapy and the marital therapy. So, I mean, this is a no-brainer, and you will develop your own style. I mean, of course we have to talk about stress, but that is exactly the point. So I'm going to step off my soapbox. I'm going to take some questions, maybe like 5-10 minutes or so, because I have to run. I have to have a meeting at holy shit, 12:30, 1 o'clock. I forgot when my meeting was, maybe 1 o'clock. Oh, I hope it's not at 12:30. Anyways, here I am.
Yeah, any questions? I know we're running a little over time, but
okay, good. So maybe we can. I mean, and you can reach out to me and let me know if you have any questions. I'll be more than glad to share my slides, as long as you don't use them without my permission, please.
If you wouldn't mind sending them to me, Dr. Lopez, I'll put them up with the lecture recording so people can have access to them.
Awesome. All righty.
And I just want to echo. I mean, I think being an outpatient world, I think this is a perfect time to start implementing that into your practice. Sometimes it can be a little hard on the inpatient side, but now I kind of think of like medication, psychotherapy, interventional, behavioral interventions to kind of encompass all those. And I really appreciate coming in and talking today.
I apologize, but I really have to run. I apologize.
Okay. All right. Thank you.
So much. I appreciate it. Thank you. Bye-bye.